Okay, I'm ready.
So if your patient is up on a pillow, that's not gonna have the spine completely aligned, right? So if I'm doing a spine, I would give them a smaller pillow or no pillow. So it's not so high. So now I'm more aligned. Alright, so what do you wanna say?
T7.
So is that an area where you can palpate or touch? Or what do we use as our landmark?
It would be 7 inches below the jugular notch.
Alright.
Would the xiphoid process be the same?
That's that's T9.
But if you wanted to use that, you can just go up from there too, a couple inches.
And what type of
And then you're going to do, I believe, no, you're going to do orthostatic.
So when do we do orthostatic?
Or is that just on the lateral?
When you're not using the AEC,
When you're going through more.
that too.
So when you're just doing the AP, I would just tell your patients to what? Taking a breath, blow it out.
Hold it.
Hold it out.
Oh, okay. What else is missing? What else is missing?
Shielding.
What you say?
Shielding.
Yeah.
And your central ray, it's a little low. So another thing that you guys could do is the top of the receptor, I think an inch and a half above the shoulder.
Okay.
And then just align to the central ray. But just looking at your collimation, you're like all the way down here, so you're getting lumbar in there. You're probably gonna get up to L3. So you could bring your central ray up more, or have her come down. So that's good, and now you could bring in your palm right. So now that's better. Now, I don't know if you guys had walked in when y'all started. Did you talk about the jewelry?
Yeah.
Like the neck, okay.
Jewelry, necklace, bra, and
Necklace, bra, and
depend upon, belts could be in the way as well. So you wanna make sure your patients take off their belts. And pretty much no zippers or anything in there.
Cause we had a lady at Camp Creek, and she didn't have on her stuff, but guess what she did have on? Her panties had
Jewelry.
You could it came up on the image. It had the
Like a
vintage,
thread?
the Savage Venti logo. Yes,
And it showed up.
it showed up. And I said, oh, so she had to go in there and take her panties off, but she didn't have. It wasn't no jewelry on them or nothing. It's just that Savage Fenty logo showed up. I said, oh, that's Savage Fenty.
You didn't tell her that, did you?
No, I told Bilal.
Okay. Cause that shit gonna make her feel bad. Like, oh my God.
Now that's what it was. I was like, oh, okay.
Rihanna charges more for that.
So I just noticed when you moved your marker, you've got the wrong side. And if you're gonna put your marker in there,
on the bottom.
put it a little bit. I would put it like here, because if it's all
Since
the way
it's
out
only
there,
doing
yeah, it's not gonna pick up in the collimation field.
Right there. Okay.
Yeah,
Okay.
but be mindful, because some places don't like you guys putting your markers here, because it'll get stuck. So we've got a lot of space, but some places, like, there's no space. It'll actually move your marker off, and it'll get stuck inside. So
So say that's the case, I know they also don't want you to put it on the patient, but
you could have just left it where you
So
were
that was
initially.
fine? even though it's not in the light field anymore.
Yeah, look. So that would have been fine.
Right there.
Yeah. All right, so while we have Ms. Wallace AP, so I'm gonna show you guys the positions for the lumbar today.
Okay.
So while we have her AP, I'm gonna kind of go back and forth, so we're not rolling her all over the place. So we'll do the AP lumbar now. So what's the central rate? Where are we going for the AP lumbar? What are we aiming at?
The crest, iliac crest.
So that's real familiar with our knees and abdomen, so nothing new there. So we're feeling for the crest. And like Miss Wallace had said, you want to make sure that you're removing the patient's pants or belt buckle, all of that stuff out of the way.
We see a lot of those like weight loss beads.
Oh, okay.
Yeah, we see a lot of those.
Yeah,
they're
they don't like to
bead-
take them off neither.
Yeah, they're like beaded. It looks like a decoration. Basically.
I didn't realize they kept them on like all the time like that.
Yeah.
Some of them are tied, and
Okay.
most
they-
of them are tied like in a knot, so they
One of
don't
my
really
good
come
friends,
off.
They hate to take them off.
They do.
With MRI, they make them take them off. And
And-
it's like, I just did this and I'm like, trying to lose weight. It's like, okay.
And then some of them, the newer ones got the where you screw it in, where you can take them on and off. Some of them got where you could take them on and off, but most of them weight loss beads, after you tie them on, it's hard to really get them off
Then they
like
tell you,
that.
oh, they tell you, oh, I just did this and this is expensive.
It's not expensive. Them beads, excuse me. You go to the flea market and get them beads for $5.
Okay, so we're centering at the level of the iliac crest, or we could also use, I know they tell you guys about using the belly button, so they might use that for this too, for the AP lumbar. So that's a good reference point. So I only moved Miss Wallace, so I'm still aligned here.
Okay.
Okay. So I'm centered at the iliac crest, and the collimation can remain the same, all right, because we're just collimating to the vertebra, because we're just getting, we want to visualize like from T12 through S1, all right. What did we talk about the legs?
Feet up, bend the knees.
So remember, if we have the patient bend their knees, a lot of times if the patient's like, oh, my back hurts, it's uncomfortable, this would make them more comfortable, and it straightens out that curvature of the spine. So when we look at the spine, remember we already talked about the different natural curves. So what type of curvature are we seeing in the lordotic?
Concave.
I'm
Concave.
saying the lumbar, but it's a concave or lordotic
Lordotic.
curvature. So by bending or having the patient flex their knees, that will help to straighten
Straighten it
out
out.
and not have that curve there as much.
Okay.
All right, so that's something we could do. So that is your, so we did AP, T-spine, AP lumbar. I was trying to find the filter. When you guys start practicing, I'm gonna look for it tomorrow. It's usually in my office and I'm not seeing it, so I'm gonna look in some of the locked storage. But remember, we talked about the wedge filter, and I know you guys were doing filters with Miss Wallace too. There's a little groove here inside the collimator track, and when you're using the filter, it just slides right in.
Oh.
Okay, so you wanna, your textbook is gonna show you images as well, but there's a thicker end of the wedge, and that's why it's called a wedge, because it's got a thicker and a narrow end. So the whole concept with that, with the T-spine, is remember in lecture I was telling you guys that the chest, it doesn't have an equal amount of thickness, correct. I was gonna show you guys with the caliper, but I'm not seeing it.
You don't see that?
We used it when we did lab.
For the cross table.
Let's see.
Let me go check, next door real quick.
I feel like you guys need like another one. for stuff. And labeled.
Yeah, now I upload these to YouTube, right? I upload these videos to YouTube.
Excuse me. Ew, I hope you have it on private.
I do.
Okay.
It just, I'm not a public person, y'all. It just, I send out the link if you want the link.
Yeah.
Right.
It
Well,
just,
I don't know where it is, and I don't wanna waste time looking for it, but the thickness here at the upper part of your chest torso, it's not as thick as once you get down to like where T10 through 12 is gonna be. We got a lot thicker tissue and density that we're going through. So in order to have appearance of equal density across the thoracic spine on your AP, remember we looked at the images and one was like really washed out on the inferior aspect of it. So to help with that and prevent that from occurring, that's where the wedge filter is going to come into
So the
play.
wedge filter goes in here,
It slides right through
and-
the screw track.
and then the thicker part goes towards the thinner part of her body.
Yeah.
Okay.
So that little thicker. Oh, let me use this punch. This will be a good. Where's the this little one? Thank you. So when you have the wedge filter, and there's all different kinds, but typically it's going to look like this.
Okay.
So you've got a thicker part and a thinner part. So it's a metal object, but it's translucent, so the X-ray beams will go through it. It's not going
Okay.
to block the beams from penetrating. It will block out your collimation, though, your light field. So that's the last thing you want to put in once you have your patient positioned, because you won't be able to see your light anymore.
Okay.
Once you slide it in. So you slide it in this way. Okay. So the thicker end will go over the thinner part because we don't want as much photons penetrating that aspect, but we do want the majority of the photons penetrating the thicker
Oh,
aspect.
yeah.
But they never, I was gonna say, they never use it. They probably don't even know where it is. I mean, most departments will have it, but they probably don't know where it is. So this is one area that you can utilize it, and you guys can see the benefit of it, you know, in the PowerPoint, the difference with the images on how they appear.
When you purchase the X-ray tube, does it come with all those like attachments? Or you're gonna so when they buy them, are they like uniform? Like if you have this or a different type of machine, they all kind of fit?
Yeah, like that wedge filter is pretty standard. So, like all X-ray tubes will have this little groove to allow for that to go in. So that's pretty standard. But like as far as all of the little extra things like the receptor holder, the filters, the grids, like everything is separate. Yeah, even the receptor. Where is it? Our digital receptor, that's separate. This alone is like $50,000.
Okay.
So everything's itemized. But yes, so that's the concept of the filter. But like I said, when you guys start practicing, I'm gonna look in our storage room and see if it's in there for some reason. So we did AP T-spine, AP L-spine. We wanna have a suspended expiration for our AP lumbar spine. So taking a deep breath in, let it all out, hold your breath. As for the thoracic, I don't think, does it specify if it's expiration too? So same thing. So the main thing with that is that we want the patient to hold their breath because we don't want them having motion on these APs.
Okay.
All right. So.
Which one is the orthostatic?
The lateral.
And then they were saying something about like when you use it, like if you use them with the AEC, I think you don't use orthostatic breathing with AEC. Like if you're using AEC.
Yes, if you're using AEC, so remember AEC is our photo timing cells, our automatic exposure control. You wouldn't use that and orthostatic breathing. Because orthostatic breathing, you have to set a manual technique. So you're not going to rely on these. And meaning, when I say manual technique, meaning that you've got to input your KB, input your MA, input your seconds, because you want that long exposure time of 3 to 5 seconds, because you want to be able to capture that motion of the breathing to help blur the ribs and the lung out the way. All right, so next, since Ms. Wallace is in laying on her back still, I'm going to show you guys how to do the obliques of the lumbar spine. So again, we didn't talk about this, we didn't get that far into it in lecture. We'll finish that up on Monday, but I just want to show you the position.
Okay.
So don't worry about the obliques for the thoracic spine. We're not going to do that at all, but you do need to just know that, well, you tell me, what do you need to know about it? Because that's going to be on your mind.
Okay.
The
Zygopathosial joint is visible.
Correct. And what type of oblique are we doing?
LPO, RPO, steep oblique.
Correct. So that's all you need to know. That you do the obliques in order to open up the zygopathosial joint space for the thoracic spine, and it's a very sharp, steep oblique at 70 degrees. You're rotating the patient. All right. But we're not going to do positions on it because we're not going to have positions on your lab test. I don't think I've ever even seen an oblique of the thoracic
I just did.
Oh, you did, really? Well, I've
Just
never.
did. And it was like, they were like, oh my God, where's Angel? Shayla was like, come here, girl.
Okay.
But I got to see it. I was like,
Where you
oh, that's
at?
crazy. At the VA.
Okay.
But they were like, we never get these.
Mm-hmm.
And it just so happened to be that same day. The day you left.
Oh, after I left?
Yeah, after you left.
All right, so we're gonna do posterior obliques. So for the lumbar spine, we want the patient in a 45-degree oblique for both of them. You have to do both. Okay, you're gonna do your left oblique and your right oblique. I believe your textbook talks about doing anterior obliques as well as an option. We're not doing that. Nobody does anterior. So we're just gonna keep it with posterior obliques because it just makes sense. You already have your patient from the AP
Yeah.
to just go into those posterior obliques. Because for the majority of the, when you see these exams, most of the time they're gonna be done with the patient laying down, usually.
Okay.
I mean, you can do them with the patient standing up, but most of the technologists do it with them laying down for the thoracic and lumbar. All right, so what oblique is Miss Wallace in now?
RPO.
Oh.
Her right side is closest to the
Table
to
or
the
something?
IR. So it's
So it's, yeah, correct, so it's RPO, right posterior oblique. I'm gonna have Miss Wallace straighten out her leg because when you straighten out her leg, you see how her hip relaxed? So now she's in a true 45 across her body. When her leg was bent, she was a little bit over rotated.
Yeah.
Okay, so be
Okay.
mindful of that. Here we can also use the ear trick
Excuse
to
me.
find the center of the body. So we'll have the patient look towards the side they're laying towards. So she's now looking towards her right side. That's why I'll bring your head back a little bit. Okay, good. So I could use the ear to visualize where the center of her spine would be. Okay, for when I'm doing my combination. My alignment. We're still going to be at the level of the iliac crest. So I'm coming down to that part.
okay.
So this is where my iliac crest is, and now I'm using her ear as a reference. Let me turn off the lights. Is that gonna mess you up, Sakosha?
No, ma'am.
So now I can use her ear as a reference for this line for centering to make sure my spine is gonna be in the center, and I'm not gonna clip any anatomical aspects of my spine. Okay? So at the level of iliac crest, and then I'm coming in towards the level of where her ear is. You can also, if you're using the iliac crest, you can also palpate the ASIS. Is that it? The ASIS, and come in medially as well, a few inches, so you could use that too.
Okay.
But you definitely don't want to be like back here, because you might get spinous process and not vertebral body.
Okay.
Because your vertebral body, you're going to shift this way, and we'll talk about that on Monday.
Okay.
And you don't want to be too far over this way, because now you're going to have body but no spinous process. Okay, so that's why the ear is a good reference point to get the spine in the center.
And with the oblique, we see the Scotty dog for the
We'll
lumbar.
talk about that Monday.
Yeah.
Yeah, but this is where you're gonna see the Scotty dog, and we'll go over all the Scotty dogs and the let it show makeup and all that. So that's your RPO, and all of these, the nice things with these, for the most part, your central ray is gonna be perpendicular.
Okay.
Okay, the only one that we're really gonna angle for is the spot on the lumbar spine. Everything else is perpendicular, so at least you're not having to keep changing the angulation of the tube like we were with the cervical. All right, I always like to start with my RPO oblique, because that way when I change the patient into the LPO and they turn towards their left side, then I just go straight into my left lateral
Okay.
instead of rolling it back and forth. All right. So now we've got the other oblique. Okay. Do you want the pillow under your head?
You can leave it out.
Okay. So we're gonna roll them to the left side for the LPO oblique. I'm utilizing the sponge, so that's gonna be patient driven, like you could use the sponge, or some patients are fine holding that position. Your older patients, I would recommend using the sponge, because they may not be able to maintain that position for a long period of time. And then just put it underneath their back, so you wanna use that 45-degree sponge or wedge. Alright, so same thing here. I'm gonna come to the level of my iliac crest. I'm gonna go down a little bit. And then I'm coming over. I'm just gonna stand to make sure I'm in alignment with my ears. So I'm gonna bring it up a little bit more. So that would be my opposite LPA. For my obliques, I always like to mark the side that's down.
Okay.
You can technically mark, I mean, you could put your marker over here on the left side or over here on the right side, but I like to mark the side that's down. So I would use my left marker and put it on this side because it's less confusing for the radiologist.
Okay.
If I have her in an LPO, but I put my right marker here, they're thinking, well, why is the right marker here? This is an LPO. So it's a little bit confusing for them. So I just always like to mark the side that's down.
See, in this instance, where would you put the marker though?
Well, you said they don't like to put it on
I
the
mean, if
patient.
they don't. I've
So-
seen them do it, but if it's a site that doesn't want you to do it.
So if you can put it on the bucket, you can, and you would just have to put it, you might have to put it,
Just on the other side.
yeah, it would be on the other side, so watch your leg, Emma. I would just move this over and put my marker like here, or here on the left side, if you're using it on the bucky, and then, put this in. If you can't put it on the bucky, you can put it on the table underneath the patient, but you just gotta remember to get it.
Yeah. Okay.
So you can put it like underneath the patient, like right here. But just, put it, but like since you guys are now starting off with this until you get more familiarized with them, just be on the cautious side and don't put it too far in because you don't want it to come out over the anatomy because then that's going to be a repeat. You don't want it to come over like right smacking your vertebral vertebra or your body because that's going to, so I would just err on the cautious side and just kind of put it a little bit further out until you get more accustomed to them and you get a good feel for where's a good placement.
Okay.
Because even if it doesn't show up, you can always annotate it on there afterwards. Worst case scenario. Alright, so that's my left posterior oblique. Now we're going to go into the left lateral. So go ahead and turn up on your side. Is this yours, Angel? You want the pillow? Okay. Bring your shoulders back towards me a little bit. Okay. So patient is going to be turned all the way on their left side for the left lateral. So now we're going to get into the left lateral thoracic spine, lumbar, and those two spot views we talked about. Not going to go over swimmers because we did that already.
Yes, sir.
You could do the swimmers on the table if you wanted to as well. You would just have the patient extend their left arm against the table, and then their right arm will be down at the side. And still same centering point, so you could do it on the table. All right, so I always like to tell my patients for the lateral views to put their arms up like they're praying, behind their face so they're nice and out of the way. We have them bend their knees because that allows for stability so they're kind of not rocking and rolling back and forth and they're maintaining that true lateral position. So, looking at Miss Wallace, do you guys think the lateral is good, her positioning?
No,
Okay, what needs to be fixed?
she needs to lean back from here more.
Mhm.
She's kind of oblique.
Yeah, so when you're doing your laterals, it's really important, whether you're doing it for the thoracic or lumbar, that you feel for those shoulder blades, make sure that their shoulders is in a good alignment and their hips. Because sometimes you might have the shoulders going this way, the hips coming that way, and it's not, you might have the hips in a true lateral, but the shoulders aren't. So you want to check both areas and make sure that both areas are in a true lateral. Okay? So once you have that, now we're going to go back to our centering. So we'll start with the thoracic region. So we're coming back up here. Watch your leg, Emma. I don't want to knock you. So we're coming back up here. And remember, you can use the top of the receptor because since now they're in a lateral position, it's going to kind of be a little bit challenging to visualize the jugular notch and feel for the xiphoid process. So you can put the top of the receptor 1.5 inches above the shoulders and then just make sure you're in alignment here. All right, and then you would be where you, more or less where you need to be for the lateral positioning of the thoracic spine. Remember we talked about a lot of your sites should do automatic collimation. Alright, so when it automatically collimates, you might see here, well, I'm not getting the shoulders, I'm gonna miss T1. Remember in our lecture, we talked about the beam divergence. So it's gonna divert out to cover the full range of the receptor. So don't worry about that. You may not see the light here, but you're gonna get that region on your image.
Okay.
Alright, so this is the position that you can use that orthostatic breathing technique to help blur the lungs and the ribs out of the way. So that it would enhance the thoracic vertebrae. Not everybody does it because it's kind of, not everyone is as familiar with it or as good with setting manual techniques, so you may not see it utilized a lot, but it is very helpful with the way the appearance of the vertebrae come out on the film. So the main thing with that is your KV, you guys, I don't know if you came across it in your readings, what's like the average KV range for your spine, like the thoracic and lumbar?
75 to 90.
Yeah, so normally you're gonna see it,
About
and
80,
90s is kind of like the extreme, those are gonna be your larger patients. But usually it's gonna be like in the mid to upper 70 range, your KV, all right? So you always wanna make sure your KV is in that range. Unless you're doing like a child, you could probably reduce it a little bit. And that goes the same even if you're using the AEC photo timing option. You would still have that same KV range.
Do we need to know the scoliosis series for like lab tests and general?
Not for lab testing. You just need to be aware of it. We'll talk about that a little bit more on Monday.
Okay.
We talked about, you know, how to recognize the signs of scoliosis on the image, the Cobb angle. On Monday, I'll talk about the differences and the cons and pros of having your patient position AP or PA for the scoliosis, because you could do it either way. And then I will also talk about the shielding, because I don't think we talked about that. But you can shield, and a lot of sites have like special shields for the scoliosis series, because again, when it's diagnosed, it's usually in pediatrics and they're doing a lot of series of x-rays. So they have special shields that they have designed for that series. Your textbook is going to talk about a specialty method where they step like on a block.
Yeah.
I can't think of it off the top of
Ferguson.
So you'll see that. That's not going to be on your test, and we're not going to have it on the lab test, but just be familiar with it because you may see it on the registry.
Okay.
So
You
if you
said we
see,
could do the scoliosis as a elective though, right?
yes,
That's an
yeah,
elective.
you'll see it in clinic. You'll see it for sure at Children's, Southern Regional, Fayette Outpatient. I don't know if the VA does it. I don't think so.
I don't think they see many pediatric patients.
Okay. Yeah, but you'll see it for sure at Children's, Southern Regional, I know Southern Regional does it, and Fayette Outpatient does it as well. So if you see it, you could comp on it. I mean, it's pretty easy. It's just really an AP and lateral, and some places only do an AP.
It looks
So-
like it only. It says PA.
Yeah, so we will, and that's fine if they do a PA, so I'll talk about that on Monday. The differences between AP and PA. But yeah, if you see it, definitely take advantage and comp on it, because it's an easy comp and it'll count as an elective.
I don't know, there was some I was gonna tell Lauren to comp on, because I noticed I didn't comp on it while I was over at OR. And I was like,
Oh, I cystograph.
Okay.
I did a cystograph, it was something else, I'll text you if I remember though.
The ERCP maybe?
It was
They do
some,
that in the core though.
yeah, it was
They don't do
something,
it
I
over
think, fluoro-wise, I can't remember, I'll look at the comp book and it will remind me.
Okay.
All right, so that's your lateral thoracic. So from here, sometimes some facilities like to do a spot view as a part of the thoracic spine series, which is basically focusing on the T12L1 region. So you just come down a little bit. I don't think it's in your textbooks, that spot view.
It is, well,
No, it's
Not for the,
not.
not, that one's for the lumbar, but this one's for the
Yeah.
T spine.
oh,
Yeah, I don't think it's in your textbooks. I'm just gonna show you because I know a lot of sites do it. But you're just gonna come down a little bit further. And usually they do this on a smaller receptor, a 10 by 12, or you can just make sure you bring in your collimation because you're just really focusing on those 2 to 4 vertebrae in that region, really T12 and L1. You still want to make sure that the patient is in a good lateral, and that would be your spot view if they require it. All right, so going to the lateral of the lumbar spine. So what's our central ray for that?
Same place. Iliac crest.
So make sure you're feeling for the top of the iliac crest. All right. Here, remember now we're going to start to see that lordotic curvature. Okay, so you want to kind of keep that in mind. You might have to adjust your central ray a little bit because you're going from a kyphotic curvature with the thoracic to now a lordotic curvature. So you want to adjust that, maybe go in a little bit more. I'm going to open back up my collimation a little bit longer because I want to make sure I get like at least from T12 to S1 on here and all of the 5 lumbar vertebrae. So that's in my lateral lumbar spine. And this will be exposure on suspended expiration. Okay? So the last one is the spot. I will talk about the spot a lot in lecture because the angle is going to vary depending on if you're doing a male patient versus a female patient. And we'll explain the differences why, and we'll explain why we are angling. But for right now, I'm just going to show you the position. So I'm going to angle 5 degrees caudad towards Miss Wallace's feet for this position. So I'm going to go ahead and put my angle on here first. So I got my 5-degree angle. Remember, I got to now come and adjust move my grids. Don't forget to do that. So now I'm aligned to my receptor. And now I'm going to go and position where I need to be. All right? So there's a couple ways that you can do this. You can put your hand at the top of the iliac crest and kind of make a C. And then come in the middle of that C. And that would be your landmark. All right? So I've got my C around the iliac crest and I'm coming in the middle. And so that is a way to get your centering point. And then I'm just going to bring in my collimation because for this, we're really only concerned about L5S1. We're trying to open up that L5S1 joint space. Okay, so your collimation is really small.
But you're still, like, position-wise, you're still in the lateral.
Yes.
There's
Yep, you still want to make sure she's in a good lateral. And if she's not, that's going to, if the patient is not in a good lateral, you won't be able to see that joint space as open, or there'll be like iliac wing over the joint space because of the rotation. Yeah, so you want to make sure they're in a good lateral. The other way is it's going to tell you to, and Lauren, correct me because you got your book, you can come back, go to the level of the ASIS, and then you can come back 2 to 3 inches posterior from that. Is that what it says?
Yeah, 2 inches posterior.
Okay. So you could feel anteriorly for the ASIS and then come back, but it'll put you in the same region. Most people you're just going to see do the little C.
That's what I see.
Yeah. So that will be your spot view to open up the L5S1 joint.
Okay.
All right. So that's it. So spine work, sometimes you'll find technologists don't like it, love it. I think at first I didn't care for it. I didn't like it because it was just a lot. At times, usually you're always doing, it's changed over the years, but starting out, it would always be an automatic like 5 views for the cervical, 5 views for the lumbar. So it's just like a lot. So I think that's why I didn't care for it. But now, like a lot of facilities just do like 3 views. They won't even do the obliques as a standard part of the routine.